Grab the mic. I like grabbing the mic. And Ola, thank you very much for your presentation. I think there was a lot of good information in there having to do with the importance of MRI first and the importance of men, especially with low risk and very low risk prostate cancer, not running to the operating suite or to the radiation suite, and how sweet it is in Sweden, I guess. But any rate, I think I'm going to turn this over to Jeff, who's going to be like the public broadcasting system person in the US and give a very brief pitch. And I also am asking representatives from the ANCAN organization, the Canadian Active Surveillance Group, and probably Throne to talk about the fact that there are other groups on active surveillance. Ours is the first international group. At any rate, Jeff, why don't you give your pitch for PBS?
Thank you, PBS. Can you hear me okay?
Yeah.
Yeah, thank you. Welcome to everybody, including my Canadian friends. I was born in Montreal and still have a hockey stick. Thank you, doctor. Excellent presentation. As a 3+3 patient for the past decade, I am hopeful for survival, and the facts greatly help. Now, if we're going to continue to get facts, people, we need to get additional funding from you. So if you would go to our fundraising site today, or email or call me, I sent a message out on the chat. We would appreciate your support. In light of that, I have recently entered and find some success on a plant-based diet. So we are offering either the Navitas or the Daiwa coupons today. For Canadians, of course, the Daiwa is in British Columbia. So again, it's important that we get your funding, and the funding brings us the truth. Thank you.
Okay, I'm entering in the window information that I tried to enter earlier, which is of interest, especially to Canadians. Any rate, well, why don't we start with Phil? If Phil Siegel can take a second and give a pitch for their new active surveillance support group, national group in Canada. Phil?
Hi, our group meets on the second Tuesday of each month. It's a newly started group, and we welcome anybody who's interested in active surveillance to meet with us. The site, I'll put the site in the chat line, but it's prostatecancersupportcanada.ca, and you can get the information on that site.
Okay, that's good. If Peter Kafka is still here, maybe he can give a little pitch for the ANCAN group, which is the first. Well, the active surveillance group, as far as we can tell, is the first weekly support group for active surveillance. But Peter, are you still with us?
I am.
So keep it sweet, as in Sweden.
Okay. So thank you very much, Dr. Brett. That was an excellent presentation. Our ANCAN organization has been running live, free online support groups for all aspects of prostate cancer for quite a few years. And I've been participating in it for some 7 years now. And we've divided up, we have groups weekly for active surveillance. I moderate a group for low and intermediate twice a month. We have a weekly group for advanced and recurrent disease. We have a group that meets once a month for guys under 60, because as you mentioned, every part of prostate cancer has a different audience and different concerns. In the low and intermediate group that I moderate, there's a lot of guys kind of trying to get guidance from peers about, do I go with surgery? Do I go with radiation? Go with focal therapy and other concerns. And guys with advanced disease have a whole different plate of concerns. So we've divided it up so that we don't scare each other and don't kind of dismiss each other because we're not concerned with.
Well, Peter, I'm going to have to dismiss you soon. So
Okay, so go to ancan.org and you can find out how to join us or hook up with any of our groups.
yeah, we especially welcome you to our weekly support group at 8 p.m. Eastern US. And then Throne, do you want to give a pitch? Throne is a true pioneer. I think he developed the first support group for active surveillance anywhere, at least as an independent group. So Throne, do you have a brief pitch?
Yes, well, thank you. But first of all, I would like to thank all the Pratt for an excellent presentation. There are a number of things which I will be able to pick up here and translate and use in Icelandic. We established, you can hear me, is that okay?
Yeah.
Yeah. We established the active surveillance group here in 2014. And the reason for it was that I was attending prostate cancer support group, but I found it very uncomfortable because the stories the men were telling there were not very pleasant to listen to. And also when I spoke about my experience of active surveillance, I felt that the others had regret because they had never heard about something which was active surveillance. I was diagnosed in 2005 at the beginning when Dr. Lawrence Klotz was getting recognition. So he is my hero because then I decided not to have a treatment, that I was on active surveillance for 14 years. But I can just say that all the men who have been part of it, we meet every second month, all the men have said, I wish that such group existed when I was diagnosed, because I have felt so much alone and so uncomfortable. So I think that having and being a part of those groups is extremely important for all men who are diagnosed. And we have just briefly at the end, we have the meeting, takes 1.5 hours. And we have what I call the round table. We go around and everyone tells about the experience, what he has learned. And men say we learn more from each other than we learn by reading books and so on. So, and we are extending our system now. We have just established last month, we established a group for spouses. And then we have, of course, a group for those who have been treated.
Well, Throne, we really got to get to the questions. So
yes, okay.
So, okay, I'm going to ask a few questions and then we'll switch off between Phil and Mark. And my question is in terms of your system in Sweden, do the men have a choice? Can they stay with the coverage that they have with your national health plan and opt for surgery or radiation, or is that only paid for through private insurance?
No, every option is always available for all men with prostate cancer. So as I said, men with very low risk prostate cancer, I shouldn't even discuss the option of surgery or radiotherapy. But there are occasional men with also with very low risk disease that just can't live without cancer. They might have had a brother dying from prostate cancer. They might have other reason for that. But clearly, if a man insists to have surgery, he will have surgery. And that's absolutely covered with the healthcare insurance. So no problems with that.
Yeah, because realize I was talking to the chairman of the National Comprehensive Cancer Network. He's here in Chicago. And I told him about this program. He said, oh, they're in a socialized system, so they probably don't have a choice, but they do. And I just have one other question before I turn it over to the other moderators. And there's a new study out, and I think your statistics are in there as well, from Dr. Catalona, also at Northwestern here in Chicago. And they report in Journal of Urology in November that about a third of men on active surveillance convert to treatment. Sounds like a religious thing, doesn't it? In about 7 years, 6.7 years. Dr. Finelli in Toronto reported in an even bigger study in Journal of Urology in September that 50% of their active surveillance patients converted to treatment within 5 years. And I wonder what the conversion rate is in Sweden. And I may have a follow-up.
Unfortunately, we don't have the statistics. I'm actually planning to do a national register study to find that out. I'm convinced that the rate of active treatment is falling over time for several reasons. As I mentioned, when we started men on active surveillance 10 or 15 years ago, we as urologists were quite anxious, and that made the patient anxious. And now we know that Gleason score 6 cancer is indolent, and we use MRI and targeted biopsies. So with growing knowledge about the indolent nature of Gleason score 6 cancer, and with much better diagnostic tools to rule out high-grade cancer, I think patients that start on active surveillance today for low-risk prostate cancer have a much lower conversion rate, but I don't know what it is.
I see. I'm going to take the moderator's option of one more question. You mentioned anxiety, and that was on my list. And there's a program, for example, in Milan, where they have multidisciplinary teams that talk to men who are newly diagnosed. And this includes urology, this includes radiation oncology, but it also includes a psychologist who screens for anxiety. And I wonder if you do any screening for anxiety and what you do about anxiety.
We don't formally screen for it. Every cancer patient in Sweden has a special, we call it in Sweden a contact nurse. In England, it's called a cancer specialist nurse. So a nurse that has much more time than the doctor has to talk to the patient, to give oral and written information. And of course, there is an offer for anyone to go to a social worker or a psychologist, but there's no formal questionnaire or anything.
I gotcha. Well, Mark or Phil, why don't you dive in?
Okay, Mark can dive in because I think most of the questions I have, Howard, were very specific. So I'll let Mark see if he wants to go forward.
Well, so we have a lot of questions in the chat room that are here. I actually thought you were going to start with the chat room, Phil.
Well, no, Mark, I've looked at some of the questions, so they're quite specific. Like, you know, there are a number of questions.
There's a lot of questions where they're asking medical advice
on cancer specific, as opposed.
Yeah.
Yes.
Yeah. No, I agree. And we're not here to offer medical advice. We want to go as far as we can without offering specific medical advice.
Why don't the two of you kind of look at it and see if you can generalize things, and I can fill in for a second.
Yeah, why don't you, do two more of your questions. And,
okay, because I'm sure you can kind of de-identify and generalize some of it.
Good, yeah, ask a couple of yours, Howard, we'll take a look at it, yeah.
All right, okay, neighboring Norway has largely stopped the use of transrectal biopsies following a highly publicized death of a patient in Oslo from sepsis triggered by a transrectal biopsy. And I wonder what, and there's a big debate. There's a movement called Trexit, transrectal exit by 2002, led by Dr. Grummett from Australia, who's on the European Association of Urology committee, and the Norwegian Dr. Johansson is on that committee. And in Europe, the guidelines give priority to transperineal biopsies that avoid the rectum. And I just wonder what the status is in Sweden. Things are sweet in Sweden, but are they sweet for transperineal?
Unfortunately, I can't say that we are very good on transperineal biopsies. There has been a slow adoption of that technique. I used to work in the UK, as I said, started working there in 2013, and transperineal biopsies were a routine procedure. I would say it's just the past 1 or 2 years that some centers in Sweden have taken up routine transperineal biopsies. So that's definitely something we have to improve, not least since the European guidelines since, well, 6 months or something,
right,
recommend transperineal over transrectal biopsies.
Here's something else. I referred to the study by Dr. Catalona talking about conversion. But they also make a point in there of a novel finding, is the way they put it, that men with high volume Gleason 6 ought to be treated like they have higher risk cancers. Now, we, in the ANCAN group, we had Dr. Klotz from Toronto speak recently, and his position was that he probably would not recommend surgery or radiation for men with high volume. We had Dr. Egner from the University of Chicago speak, and well, here's the difference. Klotz said he probably wouldn't criticize colleagues who did do a surgery or a radiation on the men with high volume. Dr. Egner was much more reluctant and much more willing to offer active surveillance to men with high volume. And I wonder what your perspective is. Well, maybe you can define what high volume Gleason 6 is and how you regard it.
Well, I would say there are many aspects of that to weigh into the equation. And one is, of course, the PSA level, the PSA density, if it's a palpable nodule, if it's a lesion visible on MRI, where it's located in the prostate, is it easy to access for biopsies? Do we really know it's a Gleason score 6 cancer? As probably most of you know, Gleason scoring is not an exact science. If you send a specimen with a supposedly Gleason score 6 cancer to another pathologist, he or she may very well say it's a Gleason score 7 cancer. We do know that the more Gleason score 6 cancer there is in the prostate, the more likely it is that there's also a Gleason score 7 component. So if I had a reasonably young, fit man with a high volume, say 6 positive biopsies or a visible 1-2 centimeter lesion on the MRI, I would, if I wouldn't recommend treatment up front, I would send the pathology specimens to another pathologist to see if it is still confirmed to be Gleason score 6 cancer. I would see over time, has the PSA risen? Has it been stable? Have we done repeat MRI scan? If the lesion has grown, I would say that's worse than having high volume. A growing volume is worse than a high volume if it's stable. So there are many factors to weigh in, as I said, so there is no one answer for that question.
Yeah, so
Howard, let me get
ahead.
back. We had promised the folks that put questions in the chat box, so we would get to the chat box. So let's start doing that. So is there evidence that repeated biopsies increase the risk of spreading your prostate cancer outside the prostate?
Well, that's a good and natural question that I've had many times before over the years. Some kinds of cancers, sarcomas rising from connective tissue, have a high risk of seeding, what we call seeding the biopsy channel. Also, bladder cancer has that characteristic. Whereas prostate cancer, I think it's been about 10 cases reported worldwide ever that there's been seeding where the biopsy's been taken. So I mean, with biopsy, tens and tens and probably hundreds of millions, yes, definitely hundreds of millions of men, and we haven't seen more than 2 or 3 cancers in the rectum of prostate, seeding from prostate cancer.
Can I ask you a follow-up on that? Well, let me ask just a quick follow-up on that. In those few cases, were they cases of more advanced cancers?
I'm not, I don't know, I've only seen the abstract, but clearly Gleason score 6 cancer hasn't the ability to spread. It's natural to think, if you're a layman, that spread of cancer to other organs is if you put a cancer cell into the blood system, it will flow away and start growing somewhere else. But that is not how it happens. It's about the biology of the cancer. If the cancer cell has gained a type that can infiltrate blood vessels and start attracting blood vessels to create a new tumor, it may metastasize. If it hasn't developed into that phenotype, it won't metastasize. You can put loads of Gleason score 6 cancers in the lungs or wherever, they would just die. So, no.
So let me return to the questions from the audience. But one thing I did want to say, Dr. Bratt, is that what I see is that in Sweden, you have created a system where you are reducing anxiety. Unfortunately, in the US, we have created a system that increases anxiety. And you heard me say early on that our effort at ASPI is to help men reduce anxiety. And to all the audience, I say to you, to do that in the US, you're going to have to take charge. You're going to have to empower yourself. The system will not empower you. You have to take back the power. So let me get to the next question. I'd like to learn more about the micro ultrasound as a tool for active surveillance. And I'll comment on that briefly because I did earlier on. I did have a micro ultrasound 6 months ago. One of the things that we like to do with ASPI is to go out and learn personally what we can about the latest technology. So I felt it incumbent upon myself to have a micro ultrasound, and that's the procedure, which is allegedly, the data indicates that it's as good as an MRI. So that having been said, Dr. Bratt, is that your opinion, and do you do that in Sweden?
I don't think that any urologist in Sweden has that kind of technology. I've tried it once in a meeting. It's excellent, and there are, I think, only a handful of studies, and those studies show, well, as you say, it's as good as MRI. But of course, that's probably a selection. And one thing that's a definite advantage with MRI scans is that you can send it away to another radiologist who can review it, and they can discuss whether the tumor has grown or not, whether it's high suspicion or low suspicion or normal finding. Whereas the ultrasound is user dependent. So you have to have a urologist that is familiar and skilled using that type of ultrasound. But I think if you do have such a urologist, the advantage is that you can repeat that scan easily when you're in clinic, whereas you can't have an MRI scan every 6 months or whatever.
You know, I think the reference is very specific to a new technology also out of Canada. It's micro ultrasound. It's, you know, it's different than, let's say, the color Doppler. So do you use micro ultrasound in Sweden?
Not as far as I know. I don't think we do.
Yeah, I'd like to sneak another question in from the audience. It's come up repeatedly, and that has to do with genomic testing, which and genetic testing, but genomic testing being testing the tumor's own DNA. And that's pretty routine in the United States. It can be relatively expensive, but insurance will cover it. But what we've noticed is in Canada, in England, in Netherlands, you know, and probably all across Europe, there's a resistance to genomic testing. And you know, is there, and I imagine the same is true in Sweden. And I wonder, is this a cost issue, or is there a philosophical difference between what goes on in the United States versus what goes on in Sweden or England?
Well, I think there's a general difference between the healthcare system in, at least in the US. I don't know much about one in Canada, but clearly it's business. And if your insurance company covers any kind of test or treatment, you are likely to have it. Whereas in a tax-funded healthcare system, we look at costs, but above all, we look at cost effectiveness. So if there's a reasonable benefit that is balancing the cost, absolutely, we'd go for it. So we are recommending genetic testing, germline testing for men with a Gleason pattern 5 cancer, if they are younger than 60 years, if they have metastatic cancer, because that's where we are likely to find the mutations. Whereas probably, I would say that the risk of a man having a low-grade prostate cancer having benefit of that kind of genetic test is not bigger than any man in the population. So then you could just go on testing anyone, and that wouldn't make sense from a financial point of view, would it?
Mark?
Well, I want to give Phil a chance. Phil, do you want to ask him some questions, or shall I just continue?
No, just continue.
Okay. Well, this seems to be a good one here. I've been on AS for several years, and I've been seeing the urologist every 6 months. But for the last 2 years, because of the pandemic, I have only consulted with him over the phone, where he has only looked at my PSA. There was no change in my PSA. Is this type of consultation adequate until personal consultations are possible? Do you want to respond to that?
Absolutely, that's a good question. I would say it depends, as always. A man with a palpable nodule needs to have a digital rectal examinations repeatedly. If, on the other hand, it's a low volume Gleason score 6 cancer, non-palpable, and you've had an MRI scan that shows nothing, I would say that the physical examination is extremely unlikely to pick up anything in a man with a stable PSA. So I think the risk of dying from a heart attack is bigger than missing progression of the cancer in that situation.
So one of my things has been to get the idea of PSA out into the public eye. I've never gone to a urologist, and I've been to 6 or 7 different urologists over 16 years, who uses PSA density at all. And for those in the audience, if you don't know what that is, you put the PSA over the size of your prostate, and that gives you a density number. And as long as it's less than 0.15, then you're a low risk or very low risk prostate cancer.
Well, Mark, I think you flipped the equation.
No, PSA is over the size of the prostate. So if your PSA, Howard, is 6 and the size of your prostate is 75, then that will give you that'll give you the number that you're looking for. So do you find that urologists in Sweden are using PSA density?
Absolutely. It's been in the guidelines since the first guidelines, 2013. PSA alone is pretty worthless, to be honest, whereas the PSA density has proven in repeated studies to be much more sensitive to finding men with a high-grade cancer. So I mean, if you've got a very big prostate, you can have 100 cubic centimeter prostate, then a PSA of 8 is what you expect without a cancer.
Exactly. Well, and so likely then, if I went to a urologist in Sweden, he would use PSA density.
He would, absolutely. It's registered in the national register. We have to register the data.
Well, these are all, again, thank you. To the audience, these are things that you should insist on from your urologist, because as I said, they never tell me. I have to ask them for what the density is. And that's the number that you want. You don't want the PSA, you want the PSA density.
Well, to be fair, if you've been notified the PSA density up front when you have the diagnosis, the prostate won't grow much over several years. So if the PSA is stable, then also the PSA density is stable. But at the time of diagnosis, yes, absolutely, you should have a PSA density as well.
Well, we still have 64 people on, so I guess we still have some interested people. Should we continue for a few more minutes here?
Yeah, that's fine. I'm starting to get hungry, but it's okay for another 10 minutes.
Okay, good. Well, let's continue then. We have people.
Well, let me tell the audience too that the questions that are not in the chat box, many of those were submitted to us ahead of time, just so your feelings aren't hurt. And also, Bill points out that you'll be receiving a survey about this session, and we want to know what you think. We prefer 5s, but anyway, just to make you aware, you're going to be asked about it. So there will be a test. So go ahead, Mark.
Howard, yeah, Mark, can I jump in with a couple of questions?
Absolutely. We want Canada to jump in here.
Oh, okay, so I'm interested really in hearing a bit more about the Swedish health system, because Dr. Bratt talked about a private insurance. So is that considered like a 2-tier system that people can take advantage of if they have private insurance?
Yes, I would say it's a double system, because everyone has the right to the public healthcare system, whether you have an insurance or not. So the 10% that have an insurance, they actually pay both with their tax bill and their insurance fee. So they actually pay quite a lot for their healthcare.
Yeah, and can a urologist operate in both systems?
Yes, most urologists who operate privately, and I'd say there are only 2 hospitals in Sweden, private hospitals, that do operate prostate cancer, one in Gothenburg and one in Stockholm. The urologists working there, working 100% privately.
So they won't accept public patients.
But occasionally there's so to speak, public urologist going in for a few weeks or doing some operations, but not as a standard practice.
Okay, yeah, so that's that's, I guess this is what Canada has always been having a big debate about, whether, to allow that kind of a, quote, dual system to happen. So I just wanted to bring that up for the Canadian participants.
Yeah, I'm not happy with the way it is. I think it should be better separated, actually.
Thank you.
So I see here a question about the how do you get the size of your prostate? You should have the size of your prostate from your ultrasound when you were first diagnosed with cancer. That they'll include the size of your prostate in that. And they should give you, you shouldn't have to calculate that. They should give you the density. And unfortunately, we in America have to train the urologists in the use of this density tool. Anyway, it's disappointing, but that's where we find ourselves. Okay, so do you incorporate the PHI test at all?
No, it's not been used at all in Sweden, as far as I know. I know that at least you guys that I've spoken to before know there's a Swedish test called the Stockholm 3 test that is used in some private practices, but it's not used. It's very similar to the PHI test when it comes to the prestanda, so to say. But it's a very small proportion of men that have an additional blood test more than PSA.
And so I'm inferring from your Stockholm 3 test that you're not embracing that test yourself.
The problem again is it doesn't only have to be effective, it has to be cost effective. And the cost is about $300, and it's not been proven to be of any additional value to an MRI scan for men on active surveillance.
Okay. Well, Howard, I know you had a couple more questions that were sent in. Do you want to do any of them?
I think we pretty much have covered it, and I think we should thank Dr. Bratt for his time and let him enjoy the evening in
Absolutely.
Sweden. So that's my feeling.
I'm assuming Dr. Bratt is having a köttbullar for dinner.
No, it actually will be salmon. It's also very Swedish.
I know. Yeah. Well, yeah, this has been a very rich experience. And I really applaud the Swedes for doing, the Swedish system for doing what it can to reduce men's anxiety.